Hello and welcome to this online lecture. I'm Dr. Felix Leung, and in this lecture we're going to look at the function of the hip joint. At the end of this lecture, you should be able to describe the function and structure of the hip joint and describe the osteokinematics of the hip joint. You should also be able to describe the muscles that produce movement at the hip and pelvis. This lecture is going to be broken up into two parts. Part A will look at the function and structure, as well as the osteokinematics of the hip. Part B will look at the muscles and the function of these muscles on the hip and pelvis. The hip joint is quite a stable, but also mobile joint. The role of the pelvis is to sustain the weight of the body. It forms the bony attachment between the lower extremity and the trunk. So the hip allows forces to be transmitted from our lower limbs through to our trunk, whether that's for standing posture when we're standing there, through to when we're moving and doing daily activities such as walking. The bony anatomical variations in the pelvis and the hip, as well as the complex array of muscles and its attachments, allow the joint to be quite stable, yet also provide the movements required. There are a large number of muscles at the hip joint, which allows it to produce the large forces that are required for activities such as running or sprinting, or even just rising up from a squatted position. If we look at the hip joint, it is a synovial joint. So it has the standard features of a synovial joint, such as the joint capsule, synovium, as well as articular surfaces. It is a ball and socket joint, so the socket part of it is the acetabulum, that is formed from the pelvis, and then the ball aspect of this joint is the femoral head, and that's the proximal aspect of the femur. The hip joint has movement in three planes, so it's a multi-axial joint. And based on some of the bony anatomical variations and some of the soft tissues available at the hip joint, it is one of the most stable joints in the body and can withstand quite a large amount of forces. If we start off by having a look at the pelvis, you will see that in the center of the pelvis we have the sacrum, here in green, number 1. And on both the left and the right side we have these three bones, the ilium, ischium, and the pubis. So you'll have each of these on the left and the right side. These are three separate bones at birth, connected by hyaline cartilage. And as you age and mature, these bones start to fuse or ossify. And these are completed, or the fusion is completed by roughly 20 to 25 years of age, forming quite a stable pelvis by then. In the center of the pelvis, you have this pubic symphysis, which is a cartilaginous joint. And being a cartilaginous joint, the primary role of it is not for movement, is actually for stability, and once again, adding to this stable pelvis. In this picture here, you will see that this acetabulum, so the socket part of the hip joint, is actually made up from all three aspects of the pelvis. So the ilium, ischium, and the pubis. You will also see some of these bony prominences, the PSIS, ASIS, and the AIIS, as well as the iliac crest. These are important sites for muscle attachment and are important for our surface anatomy to get our bearings of the pelvic region. The ball component of the hip joint is, if we look at the proximal femur, we'll see here that it is the femoral head, okay? That is the articulation, or that is the ball of the hip joint. Part of this proximal femur, there is the neck of the femur, or femoral neck, and this actually serves as an important area for our mechanical advantage for our muscles when we're contracting, so that it can produce quite a large, forceful movement. Also on the proximal femur, there is the greater trochanter, which serves as an attachment site for a number of muscles, as well as the lesser trochanter. The greater trochanter is quite a large structure, once again, for us to be able to palpate and also get our ability to orientate ourselves from a surface anatomy point of view. The hip joint is the articulation between that femoral head and acetabulum. The femoral head is 2/3 of a sphere, as you can see here. In the middle is a ligament, the ligamentum teres, which connects to this section here, and that serves as a channel for the neurovascular structures to go through. The articular surfaces are covered by articular cartilage, or more specifically, hyaline cartilage. On the acetabular side of it, you will see that there is this lunate surface, or quite a moon-like or crescent shape. And this is the articular surface for where the head of the femur and the acetabulum will be articulating or moving on itself, on each other. This articular cartilage is composed of hyaline grade or hyaline type cartilage. It lines these articular surfaces on the femoral head and acetabulum. The cartilage is quite thick at the acetabular side posteriorly and more on the top of the pelvis, of the acetabulum. And this is related to the loads that are sustained in the acetabulum. So the more load there is, the thicker that cartilage to help with force distribution and allowing smooth movement in the joint. If you look at this diagram, so this is an arthroscope within the hip, you will see that this hyaline cartilage have a quite white appearance. And these are some of the properties of hyaline cartilage with its high collagen fibers that give it the properties to allow smooth movement. Along the rim of the acetabulum, there is this ring of fibrocartilage called the labrum. Okay, it is a dense connective tissue. And also here in this diagram, this ring of cartilage increases the contact area or the surface area of the socket by about 30%. By increasing that surface area, it increases the stability at the hip, and it also increases the surface area for the forces to be dissipated through, so reducing the load or the stress within the joint. If we have a look at some of the bony anatomical variations, we'll also get an appreciation of how these will facilitate stability at the joint, or how it will facilitate movement or give it the mechanical advantage to produce the large actions or torques at the joint. So here in the frontal plane, we have an angle of inclination. So looking from the anterior view, you will see that there is this angle between the neck of the femur and the shaft of the femur. Normal is about 120 to 135 degrees. Now this changes throughout your lifetime, but as you age, throughout, I guess, most adults, this is the normal angle of inclination. This angle of inclination, it holds the femur away from the pelvis, and it provides a mechanical advantage for our muscle attachments so that when we're producing a contraction, we get a greater torque. And this is in particular for the abductors of the hip. It reduces the effort required to produce the large forces of hip abduction. If there is a reduced angle of inclination, this is called a coxa vara. Or if there is an increased angle of inclination, this is called a coxa valga. This increased coxa valga will reduce the efficiency of our hip abductor muscles. If we look at the femoral neck from a transverse view or from above, there is also a rotation of the femoral neck relative to the femur. And there is this 12 to 15 degrees of anterior rotation or anteversion, so femoral version is what this is called. If there is an increased or excessive anteversion at the hip, that will have implications on our walking pattern. Or if there is a reduced rotation or so a retroversion, okay, this will have an impact on our gait pattern. So with an increased anteversion, okay, this is going to lead to an in-toeing gait pattern. And then with a retroversion, it's going to lead to an out-toeing gait pattern. You'll see here these red dots. So the idea of that is during our hip movement, this ball will typically want to be in the center of the socket. So during walking, these dots will try to align. And because of this excessive anteversion and these dots trying to align, you're going to have the foot looking like it's toeing in. Same thing with a retroversion. These dots will try to align so that the femoral head is in the middle of the socket, and this is going to lead to an out-toeing pattern. If we look at the bony variations in the acetabulum from our frontal view, you will see that there is an angle of inclination here, or a center edge angle of about 35 degrees. This angle at the acetabulum, okay, so this is the acetabular angle here that we're talking about, increases the surface area or the contact in the socket. So this helps to increase the stability at the hip joint. By increasing that contact area, that also allows greater distribution of forces and therefore reducing the stress and the load on those articular structures, articular surfaces. If this center edge angle is reduced, that's going to lead to a reduced stability in the hip and reduced contact area. So that could also increase the stresses within those structures in the hip. If we look at the acetabulum from a superior view, so transverse view, there is also a rotation, so an anteversion, okay, of about 20 degrees. This will also have implications on stability, but also it will have an implication on our movement. So here is anterior, here is posterior. Because of this angle that you see here of anteversion, there's going to be a greater ability to flex the hip, so the hip going forward, than there is in extension. Okay, so this anatomical variation in the acetabulum will also dictate some of the movements available at the joint. The ligaments and the capsule also provide stability at the hip joint, and it also serves to limit and control the amount of movement at the hip joint. The stability and limit in movement comes from the first three ligaments: iliofemoral, pubofemoral, and ischiofemoral. And our transverse acetabular and ligamentum teres provide other support or other functions within the hip joint. If we look at these ligaments more specifically, the iliofemoral ligament, you can see from the anterior view, it is this Y-shaped ligament. It is a very strong ligament. Its main role is to limit extension, external rotation, and adduction. One of the functions of this iliofemoral ligament is that it helps to support our body weight. So it's really important for us during quiet standing that this ligament, when it's taut, helps to keep our hips locked in extension and therefore reducing the amount of energy expenditure from our muscles to maintain our upright stance. The pubofemoral is just a little bit deeper to the ischiofemoral. It is down here, and its primary role is to restrict abduction with some ability to restrict extension and external rotation. The ischiofemoral ligament is the other main ligament that restricts movement at the hip. You can see this from the posterior view. It is a spiral-shaped ligament, and if you use the fiber direction of these ligaments, this may help you picture how it will actually restrict some of the movements that it does. So the ischial femoral ligament restricts hip extension, internal rotation, and abduction. It is also interesting to note that there are no ligaments in the hip that restrict hip flexion, and therefore you can imagine there's going to be a lot more ability to flex the hip than there is to extend the hip. The transverse acetabular ligament bridges the notch, or this acetabular notch. It also forms a tunnel for the blood vessels and nerves to run through. So it provides a secure passageway for the ligamentum teres to run through, attaching into the femoral head. And as you see here, the ligamentum teres here is a pathway for our blood vessels. The ligamentum teres also provides some restriction of hip adduction, flexion, and external rotation. However, its primary role is to actually provide a pathway for those blood vessels. If we now look at the osteokinematics at the hip, our movement with the pelvis stable, okay, so looking at the femur's movement on the pelvis, we have our frontal plane movements of hip abduction and adduction. We have our sagittal plane movements of hip flexion and extension, and our transverse plane movement of internal or external rotation, or medial or lateral rotation. During normal osteokinematics, or during normal joint movement, there are also going to be accessory movement. So here, when we're looking at the movement of the joint surfaces, this is arthrokinematics. We will look at the first picture here during frontal plane. So in this picture, there is flexion at the hip. There's also going to be some rolling. So the femoral head is going to roll posteriorly, and also glide, so translate, inferiorly. So these accessory movements occur in order for normal hip joint movement. If there is an issue with this arthrokinematics of the hip joint, that may have implications on how much hip flexion or how much hip movement you can actually get. And this is important as a physiotherapist to understand some of these arthrokinematics so that we can help to restore some of our normal hip or normal joint movement if we can identify what arthrokinematics movement might be affected. Okay, this is the same for our sagittal plane and transverse plane movements. There are going to be these accessory movements in the hip joint. In this slide, you'll see that we're now looking at the pelvis moving on the femur. So if the femur is stationary and we bend forward, the pelvis is moving, but this is also hip flexion. Or if we're going from a bent position to standing back up, that's also going to be hip extension in terms of the movement, and it's actually the pelvis moving on the femur. During all of this, there's also going to be movement at the spine, in particular the lumbar spine. And it's important to appreciate how closely the pelvis and the lumbar spine are related, and movements at the hip and pelvis will influence the movement at the spine or the position of the spine. So if we look at that pelvis movement, you will see that when we rotate our pelvis, so in this first diagram, as the pelvis rotates forward or anteriorly, we call that an anterior tilt of the pelvis. If we rotate our pelvis posteriorly, we call that a posterior tilt. There's also going to be some hip movement. So in the first one, there's going to be some hip flexion associated with this anterior pelvic tilt. And the hip's going to go into a bit of an extension movement during posterior pelvic tilt. The trunk or the lumbar spine is where there'll also be movement. So in the first instance of an anterior pelvic tilt, there is an increase in lordosis during anterior pelvic tilt, while during posterior pelvic tilt, there is a reduction in lumbar lordosis. So this is movement in the sagittal plane. If we look at movement in the frontal plane, so from the front, you will see that there is also going to be lateral movement as well. So as our hip goes or as our pelvis tilts laterally towards our stance leg, there's going to be hip abduction, and that will lead to a trunk or lumbar lateral flexion. If we tilt away, if the pelvis tilts away from the stance leg, there's going to be an adduction of the hip, and this is going to also lead to a trunk lateral flexion. This slide just shows you some of the normal ranges available in each of the different directions. And as you see, flexion is, there's quite a lot of hip flexion compared to the other hip ranges. Hip extension is probably the least, and that's dictated by the bony anatomical structures as well as the soft tissue structures at the hip that limit extension. Also important to note that these are just normal ranges, and your patient or each of you will have different normal ranges of movement, and that is quite normal. This slide just looks at the amount of hip flexion and extension required during our normal walking pattern during gait. You'll see on the y-axis up here is the amount of joint angle or degrees in the flexion of the hip direction, and down here is in the extension direction. So during this first part where we're swinging our leg forward in that first heel strike component of our walking cycle, you see that you need about 40 degrees typically of hip flexion. That changes as we stand through and push our body weight forward, and then all the way through as our leg is behind the body now, there is this hip extension range that is required for our leg to be able to push off and walk efficiently.